Hi everyone, and welcome to the Orygen webinar on early intervention for borderline personality disorder. My name's Rosemary Purcell and I'm the Associate Director of Higher Education and Service Innovation at Orygen, the National Centre of Excellence in Youth Mental Health. So now it's my pleasure to introduce today's expert presenter, Professor Andrew Channon. Andrew is a consultant psychiatrist and founded the Helping Young People Early, or HYPE clinic, at Orygen Youth Health back in 2000, so almost 15 years ago. HYPE is an award-winning integrated team-based early intervention service for young people with borderline personality disorder and associated problems. Andrew's also the Clinical Director of Orygen Youth Health here in Melbourne, and he's also the Deputy Director of Research at Orygen, the National Centre of Excellence in Youth Mental Health. And as if Andrew's dance card wasn't already fairly full, he's also the President of the International Society for the Study of Borderline and Other Personality Disorders. So it's safe to say that you're in exceptional hands for today's topic, and it's now my pleasure to hand over to Andrew.
Well, thank you, Rosie, and welcome everybody to this webinar. It's a real pleasure to be able to talk to you about this topic, and what I hope to do today is to demystify some of the beliefs around borderline personality disorder and to help you to understand the rationale for why we believe that early intervention is important for this disorder. What I'd like to do first of all is just to remind people about borderline personality disorder itself. Many of you will know the diagnostic criteria, but just to go through them briefly so that people are aware of what we're talking about and that we're on the same page. Borderline personality disorder is defined in the DSM-5 as a pervasive pattern of instability of interpersonal relationships, self-image, affects, and marked impulsivity that's potentially self-damaging. The DSM acknowledges that it begins by early adulthood and that it presents in a variety of contexts. And the diagnosis is made by a combination of any 5 of the 9 criteria that you can see on the screen. Now, combining 5 of 9 criteria in any different way, along with 6, 7, 8, or 9 out of 9 criteria, yields actually 256 different combinations. So it's a very heterogeneous disorder with a range of presentations. What's important clinically is that it characteristically presents with recurrent deliberate self-harm and suicide attempts, chaotic lifestyles, tumultuous interpersonal relationships, reckless behaviours that are likely to harm the individual, such as impulsive substance use and unsafe sex, chronic dysphoria and anxiety. Mood problems are a prominent part of this and one of the most vexing issues in dealing with borderline personality disorder, along with mood instability, which is sometimes quite dramatic, and reactive aggression, which again can be clinically very problematic. That aggression is often quite out of proportion to the triggers and often yields great difficulties in seeking care because of aggressive responses. Now we're going to hand back to Rosie for a poll to gauge your ideas about borderline personality disorder before we go on with the presentation.
Okay, so we've got our first poll question here, which just asks, do you work with young people with borderline personality disorder features? So we'll give you all a few seconds to answer that one, and then we have another couple of poll questions after this. And don't forget, as we go along, if you do have any questions that you'd like to ask Andrew at the end, please send them through to us, and time permitting, we'll ask those for you. Okay, so we'll go to the next poll question, which is, do you currently diagnose BPD in young people under 18 years of age? And again, you can see the options there of yes, no, or I'm not really sure. Okay, so thank you. We can see all of your votes pouring in here. So we'll go to the final poll question at this stage of the webinar, which is, how would you rate your understanding of the rationale for early intervention for BPD in youth? And it's low, I still don't understand much about that. Moderate, I understand some of the evidence. And high, I understand quite a lot about this. Great, thanks everyone for voting in the polls. As I said, they're really helpful for us to get a sense of you as an audience. And when we've finished the webinar, we'll actually present all of the results to you so you get that feedback. And back to Andrew.
Okay, thanks, Rosie. So just to continue, everybody knows that borderline personality disorder begins in childhood and adolescence, and this has been acknowledged in the American Psychiatric Association Diagnostic and Statistical Manual at least since the third edition in 1980. But if you go to those same manuals and you read any of the sections on disorders of childhood and adolescence, you won't see any mention of this disorder in the diagnostic manuals. And this contradiction that on the one hand we acknowledge that the disorder begins in childhood and adolescence, and yet the failure to acknowledge it in the diagnostic manuals has been a significant impediment to thinking about early intervention. However, one of the myths about this is that the DSM and ICD forbid the diagnosis of personality disorder in adolescents. And in fact, neither manual says that you can't diagnose it. They do express some reservations. And it's important to remember that these manuals, that the DSM-5 inherited the DSM-4 criteria, and the ICD has been around since 1992. So really these reflect thinking well over 2 decades ago. The only exception is that antisocial personality disorder is actually explicitly proscribed in the DSM, and that's not for scientific reasons. That's because the American Psychiatric Association lawyers insisted on that. So there's no scientific basis for not diagnosing these disorders in young people. Personality disorder and personality problems usually become apparent in adolescence or emerging adulthood. And the significance of this is that this is a demographically crowded developmental period. That is, there are many milestones in development, and disruption of this development has potential to cause major downstream problems, even if the clinical features improve. It's like people are knocked off course and then continue on a maladaptive developmental trajectory. And we know that personality is still developing in adolescence, and for many years this was thought to be one of the principal barriers to making the diagnosis of borderline personality disorder in young people. However, evidence over the last couple of decades has really changed our thinking about this. This is a graph that shows the increase in consistency of traits, personality traits, across the normal and abnormal range of personality from birth right through to late life. And what's important here is that if I lined up every person in a birth cohort from the most neurotic to the least neurotic, the most conscientious to the least conscientious, people roughly maintain their order in the queue across the lifespan. There's a bit of jostling at the top of the queue, in the middle of the queue, and at the bottom, but the most neurotic person doesn't become the least neurotic person over the lifespan. So on the whole, people roughly maintain their rank in the queue. And you can see in this graph, and I'll use the cursor here to point out, that here is 17.9 years of age and here is 18 years of age, and there is almost a negligible difference between the stability of personality disorder at this point. And the point here is that at the age of 18, yes, you get the right to drink or drive or vote or smoke, but you don't suddenly get the right to have a personality disorder. There's really very little change in personality development between these ages. Similarly, the amount of any personality trait changes across the lifespan. And you can see here that the amount of change, which is represented by the height of these bars, is actually greatest after the age of 18. You can see that this bar here, aged 18 to 22, and the one from 22 to 30, has a greater magnitude of change occurring during these periods of development compared with ages 10 to 18. So these data, which are based on a very large number of studies, show us that stability or change in personality is not really a barrier to making the diagnosis of personality disorder in young people. Similarly, personality pathology also changes across the life course. And you can see a reference there to one of the papers that we've put up as a resource for you to download, which talks about personality disorder across the life course. These are data from a longitudinal study that again show that personality pathology peaks in the teenage years and then declines almost in a linear fashion right through to the late 20s and beyond. And importantly, again, you can see here age 17 to 20, there's no sudden discontinuity from adolescence to adulthood. And what we know about personality pathology, personality disorder symptoms, is that if you've got personality pathology in childhood or adolescence, this is the strongest predictor of having continuing personality pathology in later life. And this is over and above the common mental disorders and common symptoms that you see in young people. So when you control for disruptive behaviour, for depressive and anxiety symptoms, for substance use, child and adolescent personality disorder trumps all of those, predicting later personality pathology. Now, on the one hand, that's self-evident, that if you've got the problem in childhood and adolescence, you're more likely to have it later on. However, it's been a real challenge to get clinicians to acknowledge this. We also know that personality pathology has the same four-factor structure that you see in adults when you measure this in young people. These are two measures of personality pathology, one for childhood, one for adulthood, and they yield the same four factors: an emotional instability factor, an inhibitedness or introverted factor, a compulsivity factor, and a dissocial or disagreeable factor. And these, for those of you who are familiar with the five-factor model of personality, are four of the five factors that you see in normal personality, minus the openness factor. So the structure of personality, the time course of personality development are similar in young people as they are in adults. But there are some phenotypic differences. That is, the appearance of personality disorder is different in young people. And there are two principal reasons for this. One is the lack of developmentally appropriate personality disorder criteria in the diagnostic manuals. The DSM doesn't really explain what fear of abandonment, which is one of the criteria that you saw for borderline personality disorder, looks like in a 14-year-old who's not had the opportunity to have intimate partner relationships. In fact, it looks a lot more like separation anxiety. It doesn't explain what affective instability looks like in a young person when we know that instability in affect rises there is a normative rise in that following puberty. The other thing that's missing in young people with borderline personality disorder is what we call the iatrogenic phenomena. That is, the things that we as clinicians cause, the harmful things that we cause in people. Our entire health system is really geared toward inducing maladaptive help seeking in people with borderline personality disorder. Many of you will be familiar with the scenario of a person with borderline personality disorder turning up to an emergency department, asking for assistance, being told to wait, becoming increasingly distressed, and often self-harming, and then representing to the triage desk with blood dripping from them, people getting angry, an argument ensuing, and often restraint and sedation being used. These aren't native to the disorder. These are things that we create in the health system. And so these kind of phenomena are actually not common in young people first presenting with borderline personality disorder. And one of the most alarming things that we see that really struck us when we commenced doing this work was that it's much more common for young people to not present with self-harm. That is, to self-harm and not seek any care. And often when you see young people with borderline personality disorder, they'll give you a history of multiple episodes of self-harm, some of them often very serious, for which they sought no medical care. This is really one of the principal barriers to early intervention. That is, that people are not prepared to utter the name, to use the label of borderline personality disorder in adolescence. And this is culturally very deeply rooted in our health system. And what I'd like to do now is to explain why we think this is both understandable but unacceptable. What we know from a scientific point of view is that borderline personality disorder is a unitary construct across the life course. That is to say, there's no such thing as adolescent borderline personality disorder or adult borderline personality disorder. It's all borderline personality disorder, and it's the same thing across the lifespan. It's rather like talking about asthma. We talk about childhood asthma only to describe its onset when it occurs, in the same way that borderline personality disorder is the same condition. And a little like asthma, many people will grow out of it, but some people end up with life course persistent asthma. We know from the science, and you can see there are numerous reviews, there are actually more coming out, that borderline personality disorder is as reliable and valid in adolescence as it is in adulthood. There is really no major difference in the disorder when it occurs in young people or in adults. And when you use the diagnostic criteria, young people meet the criteria for borderline personality disorder, which is slightly higher than the adult prevalence rate of about 1 to 2%. And that's partly the basis upon which we argue that borderline personality disorder is in fact a disorder of young people, not a disorder of adults. This is because at puberty you get a normative rise in borderline traits, which are probably what brings the disorder to clinical attention. And in the late teens and early 20s, you see a waning of the borderline features, partly due to maturational or socialization processes. And you see this increasing gap between individuals who are high or low in personality disorder symptoms across adolescent development, ultimately revealing those people who look much more like adults with borderline personality disorder. I liken it to a kind of a rising tide of borderline pathology, and we know there are rocks under the tide. Those are the people who are going to do poorly in life. We don't know exactly where the rocks are, but we know that they're in this body of water of increased borderline pathology beginning after puberty. And more importantly, clinically, we know that those of you working in clinical practices see people with borderline personality disorder. If you work in an outpatient psychiatric setting, up to 1 in 5 of your patients have borderline personality disorder, and even more have features of the disorder not quite meeting the full diagnostic criteria. So this is a common patient group, and in fact one of the most common problems that you'll see in clinical practice, but it's often not recognised. Now, it would be a problem if we were intervening in borderline personality disorder just on the basis of a diagnosis and not because people were help-seeking or had any problems. But actually, the evidence shows that people with borderline personality disorder, young people with borderline personality disorder, are among the most unwell patients that you will see in practice. They have far greater rates of mental state disorder, that is, Axis 1 conditions, including substance use. They have worse psychosocial functioning, more psychopathology, more family breakdown, greater welfare dependency, greater involvement with youth justice and child protection. And one of the untold stories about borderline personality disorder is the health risk behaviours that they engage in, particularly sexual health risks and substance use. In our patient group, almost 2/3 of our patients are nicotine dependent, and the mean age of onset of smoking in this patient group is 12 years of age. That means that by the time these patients hit their 30s, they have significant health problems. And we know from work in the UK that people with severe personality disorder have a shortfall in life expectancy of almost 2 decades. We know that's not the only future problem that borderline personality disorder is associated with. There is a myth that this patient group is indestructible, but actually 8% will kill themselves, and that's similar to the suicide rate for schizophrenia. We know that they have lower academic and occupational attainment. They have increased risks of being on the disability pension, in fact, greater risks than people with anxiety disorders or depression. They have obviously a greater risk of a future BPD diagnosis and an increased risk for mental state disorders going on into the future, especially substance use and mood disorders. They have more interpersonal problems, greater distress, and reduced quality of life. So you can see that borderline personality disorder is associated with significant current problems and a whole raft of problems into the future. And that's why the significance of borderline personality disorder in young people is that it demarcates a group with high morbidity and mortality and a risk of particularly poor outcome. The narrow syndrome of borderline personality disorder, we're concerned with the whole raft of problems that people come with and are at risk of going into the future. This is not what I had for breakfast. This is really our summary of what we see as the approach to the treatment of borderline personality disorder. That is, we try to unscramble eggs. We wait until the eggs are completely scrambled before we let people into services, and treatment typically occurs late in the course of the disorder. We delay diagnosis until problems are entrenched, particularly functional impairment and the iatrogenic complications that I referred to are really deeply ingrained. And the problem with this is that we don't offer treatment early in the disorder, and when we offer treatment late, we limit the effectiveness of treatment, especially upon functional outcomes. No treatment in the literature has demonstrated that they can improve the functioning of people with borderline personality disorder. They certainly do a good job of reducing symptoms, such as self-harm, but they don't actually substantially change the lives of individuals with borderline personality disorder. So I hope that the information that I've presented so far suggests that prevention and early intervention have face validity, that it seems like a good idea to avert the problems that I've described before they become intractable, and importantly, to promote adaptive developmental pathways. And after all, who's going to argue for late intervention? We don't do this in any other branch of medicine. We don't tell people who come in with chest pain to go home and sleep it off and come back if it gets worse. We don't tell people who come in with breast lumps to go home and come back if the lumps spread to other parts of your body. But we do this in mental health all the time, and particularly with borderline personality disorder. We delay the diagnosis. We often don't tell people the diagnosis when they've clearly got the disorder. And in order to get intervention, we really wait until problems are so entrenched that people are really screaming for something to be done. So we've been arguing now for quite some time that borderline personality disorder is a leading candidate for the development of early intervention programs. And the principal reasons are that it's common in clinical practice, it's among the most functionally disabling of all the mental disorders, it's often associated with help seeking, and that is different to the other severe personality disorders such as schizotypal or antisocial personality disorders, where people with these disorders typically avoid treatment services. And we know that borderline personality disorder responds to intervention even in those with established disorder. So I don't mean to run down those treatments for adult borderline personality disorder. We know that even entrenched disorder can be helped. We also know that it can be reliably diagnosed in its early stages, and that it demarcates this group with very high levels of current and future morbidity and mortality. And we know that this is a key developmental period during which to intervene. Although, as you've seen, personality continues to develop over the lifespan, you saw the magnitude of change in adolescence and young adulthood is greatest. That is, borderline traits are most flexible and malleable in this age group. So this is the key time to intervene. And we know now from a range of studies that adolescent borderline personality disorder features respond to intervention. So early detection and intervention for borderline personality disorder should really be part of clinical practice in youth mental health. And we draw the distinction between early detection and intervention and conventional treatment for people who have actually established and complex and severe borderline personality disorder, but who happen to be less than 18 years of age. There are many people who happen to be less than 18 who have many years of enduring disorder. This is not early intervention, this is just standard treatment, and we think this should be uncontroversial, that just because you're under 18 doesn't mean that you don't have access to standard treatment. But we also think that early detection of first presentations of people with borderline personality disorder should be part of routine clinical practice. But we know that there are some potential risks of doing this, that early diagnosis remains controversial, that borderline personality disorder is a highly stigmatized disorder, particularly among professionals, and that patients adopt these stigmatizing attitudes even toward themselves. However, although we know that people are well-intentioned by avoiding the label, we strongly believe that avoiding the label is a form of stigma in itself. That is, it perpetuates the negative stereotypes. It means that we're all colluding with the idea that borderline personality disorder is a shameful term and a shameful diagnosis, and that we need to somehow hide patients or protect patients from this diagnosis. And the other really significant point here is that if you don't make the diagnosis, you reduce the prospects of applying specific interventions for borderline personality disorder and increase the likelihood of inappropriate interventions and iatrogenic harm, such as polypharmacy or exposing people to treatment for misdiagnosed disorders such as depression or bipolar disorder, which are often substitute diagnoses that are made. People end up on the wrong treatment and on ineffective treatment likely to harm them. But the tide is certainly turning, and the ICD-11, which will be out in a couple of years, and the alternative model for personality disorders in Section 3 of the DSM-5, which was developed for the DSM-5 and rejected at the last minute because of a lot of political infighting, both abandon any age-related concerns about personality disorder. They make it very clear that personality disorder can be diagnosed at any age. And really importantly for prevention and early intervention, they include this idea of levels of personality disorder. That is, that you can have sub-threshold personality disorder. We know that personality and personality disorder are dimensional constructs, and you can have some or a bit or a lot of these. And sub-threshold personality pathology, particularly sub-threshold borderline personality disorder, is actually quite disabling in and of itself. And the point of rarity, the point of difference between people with borderline features than those without is actually where people have none or one, not whether they meet 5 or 4 criteria, which is the cutoff in DSM-5 Section 2. Even having one borderline feature demarcates you from non-borderline individuals, and these people have higher rates of suicide attempts and about 15% more lost time at work simply by having one borderline feature. This idea of subthreshold personality pathology supports early diagnosis and treatment of borderline pathology and supports what we call indicated prevention, that is targeting people with some features of the disorder, and early intervention, that is targeting people when they first cross the threshold for the diagnosis of borderline personality disorder. However, this area is not without its risks, and we know that diagnosing personality disorder in young people means that people who might previously have been described as colourful or flamboyant or eccentric might suddenly be pathologised, and like we've seen in depression, there's the risk of medicalising what might actually be common problems among young people. However, we, in developing treatments, hope to offset this by developing simpler and safer interventions such that the intervention is proportionate to the problem at hand, that we're not rushing into intensive long-term treatments or into pharmacotherapy for borderline personality disorder at its early stages, and that the treatment should really match the severity and the stage of the problem. We've been working now for a little over 15 years developing early intervention for borderline personality disorder, and what I'd like to do is just give you a little overview of what a program might look like. The principles of early intervention are that you need to have broad inclusion criteria, and one of the key issues is limiting exclusions of people from programs. We take everybody. And there are very few reasons that we would reject somebody from our program. We will accept anybody with co-occurring psychopathology, even severe substance use problems or antisocial features as well. About 20% of our patients in HYPE have antisocial personality disorder, but we would still include those people. They traditionally get rejected from services. Early intervention services also need to view borderline personality disorder dimensionally, that is, combining subsyndromal indicated prevention and syndromal intervention, that is, early intervention for borderline personality disorder. And this might seem self-evident, but careful diagnosis is one of the fundamental principles. Often people shoot from the hip when they make a diagnosis of borderline personality disorder, and when we began this work before our workforce was more educated, many young women who were sullen, passive, hostile, happened to cut themselves, got diagnosed with borderline personality disorder, when in fact they really didn't have many of the features of the disorder. One of the other principles of early intervention is that treatments should be time limited. Young people rarely want to stay around in services for long periods of time, and all the existing programs internationally are time limited, mostly between about 16 and 24 sessions. Interventions also need to be developmentally appropriate, and the HYPE program that you can have a read about in some of the references that we've provided is adapted to be developmentally appropriate for this age group and uses an individual psychotherapy called cognitive analytic therapy, which was particularly chosen because of its capacity to be adapted for use in young people. And early intervention programs really have general aims and then specific aims. The general aims really relate to my comments earlier, that we want to prevent poor outcomes before they become entrenched, and we want to promote healthier development. And specifically, what we want to do is improve functioning, because we know that that is actually the core problem in severe personality disorder, that functional problems persist unchanged for decades in people with borderline personality disorder, even though the diagnostic criteria actually attenuate fairly rapidly. We also want to reduce psychiatric symptoms because other psychiatric symptoms like depression, anxiety, substance use are prominent in people with borderline personality disorder. We want to reduce and or prevent harmful treatment, and we want to promote adaptive help seeking. One of the paradoxes of borderline personality disorder is that this is a disorder that puts you at higher risk of mental state problems into the future. That is, this is a group who's going to need more contact with the health system for treatment of depression and anxiety disorders, but they learn very early maladaptive help seeking and end up getting less care for these problems than their non-personality disordered peers. So are we there yet? How far have we come in this work? What we know is that most young people with borderline personality disorder don't access specialised treatments, and in fact many of them don't access treatment at all. You can see on the screen a diagram that attempts to explain what levels of intervention we might attempt for various manifestations of the disorder, beginning with whole of population interventions for people who have temperamental vulnerability, going right down to standard intervention for those who are preventing with the disorder as we know it in adulthood. And so what we've argued for intervention at this stage is that universal and selective prevention programs that you can see on the screen aren't really possible with the level of scientific knowledge that we have, and that intervention really needs to begin at this level here, where people begin to show precursor signs or symptoms, but it needs to be broadly distributed throughout the health system. And this is not the role of highly specialised intensive psychotherapy services. This is where the entire health system needs to be engaged. And as we get down to these lower prevalence problems, we then get into more conventional treatment of borderline personality disorder. And right down at the tip here, if I expand the tip, you can see here that the kind of specialised therapies that you might be familiar with for adult borderline personality disorder really are the equivalent of the kind of intensive care units or coronary care units for traditional physical disorders. And what we need is broad-based brief intervention programs and high-quality care for the large number of people with borderline personality disorder in the community. We know that there are around about 100,000 young Australians with borderline personality disorder and around 200,000 adults with borderline personality disorder. The health system can't deal with all of those at the specialist level. So what is the evidence for early intervention for borderline personality disorder? There have been a number of randomised controlled trials, 5 of them that you can see referred to on the screen there, and these really represent the first wave of treatments. There's the HYPE treatment that we've been conducting. There's a Dutch treatment called emotion regulation training, mentalisation-based treatment for adolescents that's been done in the UK, and dialectical behaviour therapy, which many of you will be familiar with for adolescents, which was a Norwegian study, and then finally the use of omega-3 polyunsaturated fatty acids, which is fish oil, which was a study that we also published. Now, what do we know about these treatments? What I hope you take away from today is that we're not at a stage of recommending specific brand name treatments, and that anyone who tries to advocate for a brand name treatment is really trying to sell you something. What we advocate for is structured intervention. And in order to understand that, you need to understand what these studies have, how they've been conducted and what the comparison groups have been. So for example, in our study, we actually compared 2 active treatments. HYPE, using the cognitive analytic therapy, individual psychotherapy, was compared with HYPE plus what we called good clinical care, which was really excellent clinical care, and it was a highly structured treatment. Emotion regulation training was compared with manualised treatment as usual, with non-manualised treatment as usual. That's an error on the screen. Mentalisation-based therapy, again, compared with non-manualised treatment as usual, and dialectical behaviour therapy compared with what they called enhanced usual care, which again was not manualised. And when you read these studies, what you see is that actually all the groups in the studies, even the enhanced usual care and treatment as usual groups, improve. But the comparison treatments mean that you're not comparing like with like. In fact, we don't know in enhanced usual care and treatment as usual what they actually did in those treatments. They didn't measure that. There was no scrutiny of it. So we don't know whether they did what they said or how consistent they were. And the reason that this is important is that there is some evidence to suggest that treatment as usual might actually be what's called a nocebo as opposed to a placebo. That is, it might be harmful to patients. So comparing your structured intervention to a harmful intervention, it makes sense that your structured intervention might look pretty good. We also know that the patient samples differ in these studies as well. That two of the studies, the HYPE study and the ERT study, studied first presentation borderline personality disorder patients. That is, they did early intervention. The other two studies were really aimed at young people with suicidal and self-harming behaviour, and we don't know whether some of those were people with really long-standing chronic and enduring problems. And we also know, and this is a problem across all the studies, that there are really low rates to consent for treatment and high dropout rates from treatment, which are really unacceptably high. So our take on this is that psychosocial treatment is effective for adolescents and young adults with borderline features and full syndrome borderline personality disorder, that all interventions are effective, but structured interventions such as CAT, good clinical care, MBT for adolescents and DBT for adolescents outperform the treatment as usual or enhanced usual care type treatments. So what we argue for is structured interventions based on an understanding of borderline personality disorder. And HYPE, using CAT and also the MBT and DBT interventions, are systematised interventions with individual and family components. They're not just individual psychotherapies. And we believe that the data suggests that these extra components might be what's necessary for superior treatment outcome. That is a system of care, not just an individual psychotherapy. So to finish off, psychosocial treatment is effective for young people with borderline personality disorder. Structured interventions appear to outperform treatment as usual. No one treatment is superior, and the role that specific interventions or brands of psychotherapy might play remains unclear. We really don't even know the role of individual psychotherapy in the treatment of young people with borderline personality disorder, in addition to high quality care. What we do know is that often patients struggle to be eligible for programs, and when they get in, programs have high dropout rates. We also know that there's an absence of evidence for pharmacotherapy, and that we wouldn't recommend pharmacotherapy as a primary treatment for borderline personality disorder in young people. So our final point here that I want to make is that early detection and intervention should be a routine part of clinical practice in youth mental health, and I would recommend the Australian Borderline Personality Disorder Guidelines, which endorse this as part of routine practice for borderline personality disorder. So I'm going to hand back to Rosie for a poll, but I'd like to thank you for listening today, and hopefully we'll have time for some questions after the poll.
Thanks, Andrew. So we're starting the last poll with a question that we asked you at the beginning, which is how would you rate your understanding of the rationale for early intervention for BPD in youth? So again, low, don't understand too much, moderate, I have some understanding of the evidence, or high. And this will just be an interesting reflection for us on whether we were able to convince you of the rationale in this area. Great, thank you for voting on that one. We seem to have, yep, the majority of you have responded. And so our last poll question for today is, which of the following most accurately describes your view about diagnosing BPD in people under 18 years? One, I don't think that youth should be diagnosed. I'm not sure. Or BPD can be reliably and validly diagnosed in young people under 18. So we'll give you a moment to vote, and then what we'll do is show you the answers of all of the poll questions from today, and then we'll switch back to Andrew because we've actually been inundated with really great questions as we've gone along. We may not have an opportunity to answer all of them, but we'll certainly try to put to Andrew as many of the questions as we can that you've sent through. Are you ready to go? Okay, so at this point we're going to show you the outcomes of the poll results. So firstly, that's interesting. We have a highly engaged audience for today's webinar. The majority of you are working with young people with BPD features. So yeah, that's great, and hopefully today was a fantastic session for you. Number two. Just bear with us here while our magnificent technical expert gets all of these things going. Okay, so here's your answers for the second one. Do you currently diagnose BPD in young people under 18 years of age? So overwhelmingly, you don't, 78%, but a minority are doing that. So that's interesting. You're working in this field, but not necessarily diagnosing. So we'll go to the third poll question. And the next poll question is the first of the two that we repeated. So we originally asked you, how would you rate your understanding of the rationale for early intervention in this population? And most of you there, as you can see, said you had a moderate understanding, with about 1 in 10 of you saying quite high, that you understand it a lot, and a third of you rating that as lower. So what we can now show you, having had Andrew convince you of the rationale, let's see if that changed your results for the second poll. Look at that, we wait with bated breath. There's still one of you who is maybe not quite convinced, but that's really interesting. So most of you are now either at a moderate or a high level of understanding. So that's really gratifying, I guess, for us to know, a testament to Andrew's work in this area. And our last poll, which again goes to the issue of diagnosis. Which of the following most accurately describes your view about diagnosing? And there you see, even though at the beginning most of you indicated that you're not diagnosing young people with this condition, 83% now saying that you believe it can be properly diagnosed in young people. So that's really fascinating. So what we're going to do is reveal ourselves again. I'm going to pop up on the screen, and we'll get Andrew as well to pop up. There you go. I will sit back a little bit. And Andrew, there have been some really fantastic questions come in. One that captures a theme of a number of people is, what's the proportion of patients who meet criteria for BPD that don't have a history of traumatic attachment or abuse in childhood? So a number of people have been asking about this issue of trauma and its relationship to BPD.
So that's a really great question, because it comes to the heart of one of the issues that people who might be reluctant to diagnose the disorder will often raise, that is that it's really a sequelae of trauma rather than a disorder in itself. The evidence suggests that about 50% of patients have a history of significant childhood trauma or of abuse or neglect. And in fact, neglect is one of the important pathological mechanisms, not just abuse, physical and sexual abuse. And in fact, neglect is probably more pathogenic than the others for borderline personality disorder. So it's about 50%. And that means that 50% of people who develop the disorder don't have a background of this kind of trauma. And so while it's important to work with it therapeutically, we know now there's quite a large body of evidence that shows that childhood trauma is a risk factor, but it's a weak and non-specific risk factor for borderline personality disorder. It's actually a risk factor for virtually every mental disorder. So it's not specific to borderline personality disorder. And in fact, if you are exposed to trauma as a child or an adolescent, that actually the most likely problem that you will develop is either not developing a disorder or developing something other than borderline personality disorder. So most people exposed to trauma actually still grow up to be healthy people, but of those who are exposed, who are going to develop a disorder, the majority will develop a mood disorder, an anxiety disorder, not borderline personality disorder. So there's something special about individuals with borderline personality disorder that sends them on that pathway. And I often liken it to the seed in the soil, that the seed of trauma needs to land on fertile ground. And we think that what the fertile ground is probably the temperamental characteristics of that individual that mean that childhood trauma leads to the development of borderline personality disorder.
Great. Another really interesting question that's come in is the main barrier to BPD prevention and intervention diagnostic, or does it reflect the inadequacy of training in this area and the lack of understanding of BPD in the mental health and the greater community?
So I think they're all important points that have been made. I think the last point is really the most important one. I think there is a lack of understanding. I think the evidence that I've presented, that, you know, some of which is now 15, even 20 years old, takes a long time to filter into the mainstream. And so there is a lack of knowledge about the field. I think the principal barrier is stigma. And I think that you can make the argument for early diagnosis on scientific grounds very convincingly, but the stigma issue is one that is very hard to overcome, because there is actually good scientific evidence now to show that people are stigmatized. It's a real thing, and that if diagnosing the disorder is just going to get somebody worse treatment or have somebody victimized, then it's certainly, I would advise not diagnosing the disorder. That it's important to diagnose it in a setting where this is going to lead to a positive response and to effective intervention. So I certainly wouldn't advocate diagnosis at all costs. But I think, as I said earlier, we really need to stand up and advocate for people with borderline personality disorder at any age, but particularly young people. And I think the onus is really now on the naysayers to justify why they wouldn't make the diagnosis and why they would deny evidence-based treatment to this patient group. The scale is really tipped toward the evidence supporting the diagnosis and treatment of this disorder, and people who don't want to do that really need to have a strong justification for doing that. We wouldn't do that for psychosis nowadays, for example, whereas at one stage early psychosis was a controversial area. Now it's accepted that early diagnosis and treatment is not only desirable but effective and leads to good outcomes.
Great. Our question board has been lighting up as you've been speaking. Unfortunately, we're not going to get through all of the questions, but maybe just a last one that, again, a few people have raised, and that's the question regarding, so the specific question is, why do women with autism or Asperger's sometimes get misdiagnosed as BPD? And what do you see as the key differences there?
So that's a really interesting question, and there's been really very little work done on this question, partly because recruiting people like that into studies is quite difficult. You're absolutely right that sometimes young women are misdiagnosed, but sometimes young women with autism spectrum disorders can have both. And we've had a number of people through the program with both disorders. It's not common, but we do have this. And I think essentially the misdiagnosis is really more around the behavioural phenomena and the interpersonal difficulties. But if you think about it, autism spectrum disorders are actually trait disorders. They're not mental state disorders. They're present early in life, and their picture is more like a trait disorder. And so once upon a time, many of the people who are diagnosed with autism spectrum disorder would have been diagnosed with what was called schizoid disorder of childhood, or even schizoid personality disorder. So you do see this overlap, and I think that grey area is an area that we need to do some work in. And I think when people apply the conventional diagnostic criteria, that certainly helps to clarify some of the difficulties. So I don't think it's always an either-or diagnosis.
Fantastic. Andrew, thank you for your time today. We have come to the end of the webinar, and I'd just like to remind everyone that we have a survey, an evaluation at the end to get your views. One of the last questions that's come in is, I'd like to hear more about what good quality case management looks like, and that's a fabulous plug for the next webinar in our BPD series. So on Tuesday, July the 28th at midday, Dr. Louise McCutcheon, who works with Andrew in the HYPE clinic here at Orygen, will be presenting a webinar on what is good clinical care for young people with BPD. So to those of you who have been asking those questions of what does it actually look like, that webinar will go through all of that in quite some detail for you. So we look forward to you being able to join that one for us as well. Just to recap, there have been a number of questions that have come through, but today's webinar has been recorded, and Andrew's slides as well as his voiceover will be uploaded onto the Orygen website at a later date, and we'll keep you posted via the emails that you've registered for today's session with. Because we have more questions than we have time to answer, we'll collate all of those, and the members of the HYPE team will put their responses together and upload those onto the website as well. So each of those individual questions that you've asked, we will attend to. And just as a final note, our next webinar actually in this series will be held next Tuesday, and it's on a different topic. It's treating complex depression in young people. It's on Tuesday, July the 21st at 1 p.m. Eastern Standard Time, and that will be presented by two of our clinical psychologists and senior researchers here at Orygen, Dr. Alex Parker and Dr. Sarah Hetrick. So we look forward to you joining us again next Tuesday, and thank you very much for your time today. Have a great afternoon, everyone.